agree with me that importance of this topic is very relevant for each healthcare system. Let's remember with you which main priorities of modern healthcare system in each country. First purpose, health protection of so-called practically healthy people, or maintenance of healthy life. And second purpose is maintaining the quality of life of patients. Patients with chronic diseases, usually hypertension, ischemic coronary artery disease, bronchial asthma, and others. Maintaining the quality of life, their life, in addition to the prevention of complications of disease, recurrence, and disability. I want to remind you global causes of death in modern conditions. Now, of course, these statistics doesn't include information about infectious diseases such as COVID, new infections. But despite on this a new factor, cardiovascular diseases take first place, maintain this group of pathology keeps first place or most important place in the all causes of death, general death causes. More than 31% in different countries. This parameter may be variable, but maybe even more in first place. So we should all our interventions in medical practice in health, we should orient mainly, firstly, on time detection, diagnostics, treatment, and of course, prevention of cardiovascular diseases. I'll remind also for you some facts from history of medicine. Around 120 years ago, cardiovascular mortality was less than 10% of all deaths in the world. 10%. Now I've demonstrated for you that already more than 30. 21 years ago, cardiovascular mortality level was 50% in developed countries, economically developed, 25 in developing countries. Why so difference? In developed countries, despite on very comfortable life, very high level of psycho-emotional stress for population. And usually the stress associated with low physical activity, inefficient physical activity, sedentary lifestyle, which predispose these conditions can predispose to early development and progression of cardiovascular diseases. In Russia, in our Russian Federation, all non-communicable diseases can cause 75% of deaths, 40% of deaths before 60 years of age. in 2025 year, expected around 25 million deaths from cardiovascular disease in the world each year. 25 millions. And 1 from 3 deaths will from coronary vascular disease or cardiovascular disease. Unfortunately, in our country, in Russian Federation, mortality death rate higher than in United States, European Unity, United States and Japan, more than 4 times higher. Here you can see a rating for top 10 countries with the highest death rate from heart disease due to stroke and high blood pressure or hypertension. Russian Federation, as you can see, on first places in male and female population too. In some countries, students which present here, Brazil, of course, better, significantly better than Russian situation, but not so good as in United States. Let's think why this situation. But before, let's remember a few main proportions of cardiovascular deaths caused by different reasons. Ischemic heart disease, you can see here a red color, 46% for men, A, left round, and 38% from female. On second place, cerebrovascular diseases, chronic ischemic brain ischemia, for example, due to arterial hypertension usually. And on third place, hypertensive heart disease, which causing hypertrophy of left ventricle, diastolic dysfunction, and heart failure. On this slide, you can see 7 leading risk factors for premature death. Risk factors. I hope you can remember this. What does it mean? A risk factor, factors of environmental or internal nature, which can accelerate, can predispose to development of any diseases. In this list of leading risk factors, this list includes arterial hypertension on first place, 55.5%, anemia, 23%, smoking, 17%, insufficiency, unhealthy diet, and low concentration, low part of fresh fruit and vegetables. And obesity also associated with unhealthy nutrition usually. Of course, together with physical inactivity. As for alcohol, the influence of alcohol and smoking, but also almost obesity. So more attention we should pay for arterial hypertension, dyslipidemia, and smoking. For prevention, timely prevention, primary and secondary prevention of cardiovascular disease. We should remember also that death, cardiovascular complication, occur usually suddenly, especially when a full-fledged, specialized medical care often cannot be helped. But fortunately, in most cases, vascular disease we can prevent by acting by correction of modifiable risk factors. Constant, regular medication risk factors correction, such as hypertension, dyslipidemia, can reduce probability of cardiovascular events. Let's remember, what does it mean, concept risk? Risk is the probability of an adverse effect of any process, adverse event of any process. The risk, medical risk, or risk for health is the likelihood that people who have been influenced by some factors or risk factors, there will be a specific disease development or its disease complications. For example, the risk of MI development for patients with arterial hypertension. Which methods, which instruments we can apply for rapid assessment of the individual risk level? It was suggested at least two models or approaches for this risk stratification or determination. The European system, so-called systematic coronary risk evaluation, abbreviation, and Framingham model, American. These models has a gradation of risk values, low, medium, high, and very high. Framingham model estimated the risk of morbidity and death. Model of SCORE evaluated only risk of death from disease associated with atherosclerosis in over 10 years in patients who don't have proven coronary artery disease. SCORE model includes some simple parameters which we can know: patient's gender, age, smoking status, blood pressure, systolic, and the value of total cholesterol. As I said, it's systematic coronary risk evaluation can predict any fatal cardiovascular events associated with coronary atherosclerosis. And this scale also, this instrument can determine how much risk to fall deduced under the influence of any medications, for example, or non-pharmacological factors such as diet or physical activity, improvement, optimization of physical activity level. Now, you can see on your screens the most actual recent model of SCORE. so-called score 2, version 2, previous version doesn't include didn't include HDL cholesterol. Total. Previous version included total cholesterol. This scale, as you can see, instead of total cholesterol, includes most informative for cardiovascular risk prognosis and evaluation, non-high density level cholesterol, or low and very low density, most dangerous, most important for development of cardiac events, coronary events. As for others, as I said, already systolic blood pressure, patient's age, we can use this scale from 40 to 69 years, and specific modification of this scale also include additional scale for old people, and it calls score 2OP. So for older, you can find this scale if you are interested in special document. These documents, this document I also can show you. This document, for example, it is recent 2021 year published the European Society of Cardiology guidelines on cardiovascular disease prevention in clinical practice. You will discuss this topic, but already on 6th year. In 6th year of your education in our university. Unfortunately, for 6th year students, we haven't lectures. So this material of this lecture, you will apply in even 12th semester. Well, I can show the content of this version of recommendation, very informative, and also we can find here score model. There are many new information from positions of evidence-based medicine. It's more than obligatory requirements to use in practice, to apply for recommendations. Recommendation with high evidence class and a level of evidence. A level is most. B also high, but not very high. What you can see here also model, additional, so-called scale for average years free of cardiovascular diseases. And for estimation of this risk, we should know also concentration of non-high density lipoproteins and systolic blood pressure. It's also modification of the scale. So I can download, if you want, I can download this document to our chat, and you can submit. I will submit, and you will download it and for more detailed reading and investigation. There are many links, list of references. And I'm searching applications. Applications, no, already. If you want to read this document more detail, tell me. All right, to the chat. Now let's continue our lecture. According to score scale, we can see, we can define the different levels of individual risk of fatal or non-fatal cardiovascular events. Okay, I will submit some later in break, during break of this clinic. So you can see that more old people and with highest level of blood pressure, and smokers, they have a higher risk of unfavorable cardiovascular event than in other people without this risk factor, more expressed risk factors. As you can see, a green color illustrates low level cardiovascular risk events risk less than 2.5% for patients younger than 50 years old, and less than 5% for patients younger than or between 50 to 69 years old. It is low risk, moderate risk. Yellow color, between 2.5 till 7.5 for patients younger than 50 years, and between 5 to 10% for patients between 50 to 69 years old. And third group, more high risk or even very high, more than 7.5% for relatively young people, for people younger 50, and more than 10% for patients older than 50 years old. Each level corresponds to concrete value of non-high density or low density lipoproteins, and a concrete level of systolic blood pressure. Both parameters, systolic blood pressure and cholesterol, non-high density cholesterol level, we can correct by pharmacological and non-pharmacological interventions, such as physical activity and diet. So complex correction can help to reduce the total risk according to this scale. And we should, the measurement of this risk, especially for patients with confirmed cardiovascular disease, I think not less than 2 times per year, maybe more often. Now I will remind for you main risk groups of risk factors for cardiovascular disease development. There are non-modifiable. This group includes sex or gender, age, family history, and in some cases, a race, especially for Black race, which higher associated with high risk or risk of hypertension. As for family history or genetic predisposition, this connection means that development of cardiovascular disease in close relatives, the mother or father of patients, for men younger than 55 years. For example, MI for patient's father, in case of patient's father in his age, for example, 50 years old, indicates on existing genetic predisposition towards ischemic heart disease. Same situation for women younger than 65 years old. MI, for example, in age 60 years old for patient's mother, indicates on genetic predisposition. Now, let's characterize modifiable, which we can correct and which we have to correct timely, as soon as possible, of course, with adequate timely control of patients, of performing your recommendations by patients. So high normal blood pressure level or arterial blood pressure more than 130 for systolic and more than 85 millimeter mercury for diastolic blood pressure. Arterial hypertension, of course, too. So systolic blood pressure more than 140, diastolic more than 90. Low tolerance to carbohydrates due to obesity, due to low physical activity, due to unhealthy nutrition, which includes high concentration of easily digestible carbohydrates, especially. Overweight also associated with decreased tolerance to glucose. Hyperlipidemia is also very often may be associated with diet problems. A lack of exercises, it's a typical problem for modern cities life, especially for people who used cars day by day and who can't even walk during working day in his office or in his yard or garden due to lack of time. Psychoemotional distress, this top manager's symptom, as you can see, possible. Appropriate picture on your screens. Now, the attention, psychoemotional distress. It is not usual stress. It means almost constant stress day by day on high level. This constant influence of high stress levels causes stable elevation of tension due to stable elevation of high blood pressure due to constant releasing of high concentrations of stress hormones such as corticosteroids and, of course, epinephrine. Very often, psychoemotional stress can lead to dependence from nicotine. This substance all smokers can consider as a relaxative factor, sedative factor, relaxative relatively can cause minimal relaxation, but next step, unfavorable, most significant, of course, dependence. Then patients should increase dose of or amount of cigarettes. And also very unpleasant risk factor or already disease, chronic serious disease, which can increase risk of cardiovascular death. It is diabetes mellitus. As you know, all patients, especially more than 60 years old, 60 years old plus, they had higher risk of cardiovascular death due to association, due to COVID, if they had association, if they had diabetes mellitus, type 2 especially. Traditional risk factors determine more than 80% of coronary heart disease cases. If you remember, our previous lecture was devoted to problem of evidence-based medicine. But according to special clinical trials which organized from positions of evidence-based medicine, 3 prospective studies involving more than 384,000 patients. So very big population. And no, the attention observation period was also very long, more than 20 years. First place, because hyperlipidemia, then total cholesterol exceeds 5 millimole per liter. Hypertension, also next factor, systolic BP more than 140, diastolic more than 90 millimeters, diabetes, and smoking. And smoking. Here you can see main risk factors for the development of hypertension. For this very widespread, note your attention. We should measure not so traditional parameters such pulse pressure. Pulse pressure, it means difference between systolic and diastolic blood pressure. Then patients for men higher than for men older than 55 years, for women older than 65 years. We should measure this parameter. Then higher this parameter, pulse pressure, then the risk for hypertension also higher. Of course, smoking influencing very unfavorably. Dyslipidemia, then total cholesterol more than 5 millimole or 190 milligram per deciliter, or low density lipoproteins level higher than 3.3 millimole per liter and 115 milligram per deciliter, or high density cholesterol level less high density, so-called useful cholesterol, or less than 1 millimole or less than 40 milligram per deciliter for men, and less than 1.2 millimole or 46 milligram per deciliter for B-man. And last component of this repeat profile, triglycerides level higher than 1.7 millimole per liter or 150 milligram per deciliter. All these laboratory parameters we can measure regularly for patients, especially with genetic predisposition to cardiovascular diseases. Additional risk factors for hypertension are fasting plasma glucose more than 6.1 millimole per liter or between 102 to 125 milligram per deciliter. Test for glucose tolerance. Test tolerance for glucose more than 7.58 millimole per liter after 2 hours. After intaking or drinking 75 gram glucose, so-called sweet tea. Family history, we should specify for these persons family history of early cardiovascular disease for men less than 55 years and more than 65 years for women. And very famous, but not so for in doctor's practice, parameter visceral adiposity, waist size more than 1 meter, yeah. For men, abdomen size, diameter, and 85 for women, less than for men. On this picture, you can see association between different risk factors, how these risk factors association can potentiate the summary total risk of any cardiovascular events, multiplication of risk. So then risk factor coexist. The sum of their combined effect is often much greater than the sum of their individual effects. For example, multiplying to 60 times higher than for triple combination than individual. Here you can see that very high systolic blood pressure level, smoking, and the very expressed hypercholesterolemia more than 8.5 millimole per liter. Few words about cholesterol as about modifiable risk factor. In the United States, it's been estimated almost 100 million people, they were investigated and been estimated that they have elevated total cholesterol level more than 5.2 millimole per liter, and 38 million people with level of else higher, more than 6.2 millimole per liter. Early trials have shown that reduction in total cholesterol results in a reduction in the incidence of coronary heart disease events. It was performed also recent meta-analysis of 38 independent trials. It's also principles of evidence-based medicine. So this analysis has shown that for every 10% reduction in total cholesterol, 10%, for example, from 6 till 5.2, for example, more than 10%. Coronary heart disease mortality due to MI is reduced by 15%, and total mortality also decreased by 11%. Thus, total cholesterol is modified, was proved by this investigation. Total cholesterol was confirmed as modifiable risk factor for coronary heart disease and total mortality. Here you can see some results of some examination of association between high density cholesterol level and coronary heart disease risk. As you can see here, the risk of total cholesterol was higher, especially for elderly people, more than 60. Of course, higher, but no, the attention, higher was risk than was normal cholesterol and very high, more than 6.2. Intermediate level of cholesterol was not so high risk, not so high risk. As for low density lipoprotein, this type of cholesterol has been recognized as a prime target for lipid intervention to prevent coronary heart disease. About 22 million people would be suitable for drug therapy, also only 5.5 million people are actually treated by lipid modifying therapies because it's not so cheap treatment, and patients shouldn't take it day by day. Intensity of intervention or correction depends not only on raised cholesterol or LDL cholesterol level, but also on the presence of a number of other risk factors for coronary heart disease, such as smoking, unhealthy diet, low physical activity. And else one important information, increased cholesterol, increased on 1% in population, increases the coronary heart disease associated with mortality on 2%, and otherwise lowering cholesterol on 1% reduces coronary heart disease mortality on 2%. But now the attention, lowering cholesterol level was proved by 26% reduces the likelihood of coronary events by 47%, almost by 50%. And now the time for break. I'll submit clinical guidelines, and you please write to our chat, group leaders especially, or any other group members, how many students and who are present now on our lecture. Thank you, and 10 minutes break.